Good evening, everyone. Welcome to the live panel discussion and the Q&A session that we'll be having tonight with some of our presenters. I'd like to welcome you all to the Congress of the Romanian Society of Lifestyle Medicine. We're really thrilled to have this first Congress this year in Romania, and we're really thrilled to have some of the what we would call the titans of lifestyle medicine participating and helping us bring lifestyle medicine to Romania. Our panel tonight is made up of some people that you may already have seen tonight if you've been following our presentations. And I'd like to just take a few seconds to introduce each of our panel members. So please bear with me while I share the screen. I will be your host. My name is Konrád. I'm Vice President of the Romanian Society of Lifestyle Medicine. I'm a dietitian and a physician. And today we'll be trying to answer your questions. In our team tonight, we have Emma, Dr. Emma MERCORE HUţANU. She is the president and founder of the Romanian Society of Lifestyle Medicine. She's a family doctor. She also qualified in plant-based nutrition and lifestyle medicine. She's a member of the editorial board of Wiley, Lifestyle Medicine Journal, and she's done internships in the USA at the Bernard Medical Center, where actually Dr. LOOMIS works, who is on our panel tonight. And she's also done some internships in Japan. So she's been from east to west, and she's going to be answering your questions together with other panel members. We also have our keynote speaker joining us tonight, Dr. DIEHL. Dr. DIEHL is a lifestyle interventionist. He's a researcher and author. Some of you may know some of his books. Before getting to know Dr. DIEHL, I have about 4 of his books on my bookshelf as well. So it was a privilege, and I was very happy that I could actually meet him in person at the Congress. Of course, if you're a researcher and author, it often goes hand in hand with being an educator, a speaker and a presenter. And maybe Dr. DIEHL is best known for the world famous CHIP program, which is the Complete Health Improvement Program. And it's a very successful program for reversing a lot of modern chronic diseases that's had over 100,000 patients go through it. And I'm sure you're going to hear more about the CHIP program during the Congress. Also on our panel tonight, we have Dr. Rob Lawson. Dr. Lawson is from Scotland, which is where I grew up. So I feel like we have something in common there. He is the president of the European Lifestyle Medicine Council, chairman of the British Society of Lifestyle Medicine. He's a GP, and he's very interested in promoting and works for primary and secondary prevention. We also have Dr. James Loomis joining us tonight. And I said, as I already told you, he works at the Bernard Medical Center. He's actually the medical director there. He's also a diplomat of the American Board of Lifestyle Medicine, and he has been a board member of the American College of Lifestyle Medicine. We have Dr. Dan Nicolae joining us, and he's a pioneer of lifestyle medicine here in Romania. He's the director of the Hergelia Health Center, which is oldest running health center in Romania. It's been running for 25 years and has seen literally thousands of patients going through it, where they've been going through lifestyle change and learning about what they can do to improve their health there. He's co-founder of the American College of Lifestyle Medicine, adjunct assistant professor at Loma Linda University in California, and associate professor of nutrition and dietetics at the University of Medicine, Pharmacy, Science and Technology of Târgu Mureș. He was actually one of my professors when I was studying dietetics at the university here in Târgu Mureș, where I currently still reside. So just so you guys know what will be happening tonight, this is for all our viewers. We're going to have a split session. The first part will be a live panel discussion, which Dr. DIEHL will lead out in. And the second part will be the Q&A session, which is where we will be answering some of the questions that you've been sending in over the last few hours since the conference platform has been open. So until about 8:40, I'm going to give the mic over to Dr. DIEHL. And then in the meantime, if you're watching and you have any questions, please send your questions in so that we can process them and get them ready for the panel to answer. So Dr. DIEHL, take it away.
Well, is everything set well? Am I on?
Yes, you should be on.
Very good.
Everything should be working.
Well, I tell you, it was about 30 years ago that I saw for the first time the word lifestyle medicine. It was used by Dr. Winder, an epidemiologist, and it clicked. And it started at that time for me to begin to think about the chronic diseases that were not really responding very well to pills and procedures in going beyond making people comfortable. And it was at that time that we developed the CHIP program, and ultimately it turned into the creation of the American College of Lifestyle Medicine. And I had no idea. It is a dream come true to see how lifestyle medicine now has become a social movement with global tentacles. And my greatest joy today is to see the tentacle reaching out into Romania. And I'm just plainly excited to see what you folks have done to make this the launching of, what shall we say, a seismic revolution in medicine.
Hopefully that's what, I mean, I'm telling you, Romania needs lifestyle medicine more than ever. And I'm hoping that's what's going to happen, what you're saying.
Yeah, and since we have three titans, as you call us, from Romania there, I was very, very interested as a panel member to have a better idea of what is health like in Romania. And so I'd like to ask a few questions, because if we really think that we can offer something as a possible solution in lifestyle medicine to Romania, we probably need to first have a better understanding what is health like in Romania. And so my first question is, how do we do in Romania with regard to lifestyle expectancy, life expectancy?
Okay, I'm going to pass this question first to Dr. Dan. He's the one who's been the doctor in Romania the longest among the three of us. And then afterwards, Emma, if you'd like to also please answer the question.
I think we are about 6 or 7 years under what currently people live in the Western states. And we've been behind during the communist time, and as the markets open, the influx of Western refined foods and Western lifestyle didn't help us to catch up with the life expectancy in the West, unfortunately.
Okay, thank you. Emma, if you have anything you want to add.
So Romania is really struggling with increasing their lifespan. As you suggested, it's about 6 years below the EU countries.
Yeah, 6 or 7 years.
Yeah, is there a difference between the educated people versus the perhaps people on the other side of the spectrum in terms of life expectancy?
Unfortunately, in Romania, we don't have good statistics. Probably one of the best area where we have good statistics is diabetes. There was a group of researchers who did a study which was published in one of the best journals. Predatory is the name. So we know more about diabetes, but we don't know details about how lifespan goes across the social, economical, social strata in Romania. I'm not aware. Maybe Emma knows something about that.
Yes, if you are okay with microphone, it's fine. Okay, it's open. Yeah, there is a little gap between genders regarding this subject. There is actually a woman living on average 7 years longer than the man, and as well, the educated people tends to live longer, and uneducated people tends to live less because of the behavioral disease. And this is a real problem. This is a thing we have to deal with, and to address it, the root cause, starting with educating the people, and then to shift to a behavioral education, and encourage people to take care about their health. There are a lot of things to improve, unfortunately, in this section in Romania.
What Emma's saying, I was just thinking when she was talking about the behavioral part. I think one of the problems that we faced here in Romania is high rates of smoking. We still have a lot of smokers, and I think this is a contributing factor. I mean, I'm amazed. When I was attending medical school, I was very amazed how many of the medical students and, you know, other students from other health professions, pharmacists and dentists and dietitians and so on, they would go out between classes and there'd be big groups smoking behind the university. And I was actually very surprised to see that very often I saw more girls smoking than guys among the students at the university. So these are problems that we're definitely going to have to be looking in the eyes of in a few years when these people become highly addicted to the habits.
So the gender difference in age in life expectancy apparently could partly be explained by the difference in smoking behaviors, because men seem to be smoking much more than women in Romania, as I have read.
Yes, around half of all deaths in Romania are attributable to behavioral risk factors. 1 in 5 Romanian adults are daily smokers, as my colleague used to mention, and higher rate among men, 32%, than women, 80%. Alcohol consumption is a major public health threat also, with the binge drinking rate very high. 35%, far exceeding the European Union average of 20% in men, and this rate is very bad.
So alcohol abuse, you mentioned binge drinking, is fairly common among men.
In men, far exceeding the European Union average of 20%. This rate is over 50% in Romania. It's pretty bad.
So we have to really work and focus on those men, right? I mean, you mentioned smoking and you mentioned alcohol now. Okay. Anybody else wants to make a comment on this? Okay.
No, Dr. Dill, in 25 years, we've seen about roughly 25,000 patients who went through our lifestyle program. And it's true that educated people are more likely to make lifestyle changes, but in the same time, because the continual change in society, we adapted to the capitalism, and it was a transition. All these 30 years there were so many changes. There is a tremendous pressure on highly educated people, on those who achieve something, and so we've seen these of course, it's an observational information. We've seen that these in the patients who came, and I really believe that the model which was presented here, in which stress management and social support and all those factors should be part of lifestyle medicine, I think they are very true for Romania. And we've been using them very successfully in our practice.
So you're talking about the society is in transition, right? Your social habits being changed from a communist regime to a capitalist system. There's a lot of turmoil, turbulence, stress, and that looks for some relief, possibly by smoking and drinking, right?
Yeah, of course.
Mm-hmm. Okay, so this is the life expectancy question. I wanted to dig a little bit deeper now and maybe look at the chronic disease rates. What are the three major common chronic diseases in Romania now?
I will go to answer this question, dear Dr. Hans. Unfortunately, I'm working on the ambulance car in my daily life, and I'm seeing how the Romanian people are dying, not because of accident crashes mostly, but ischemic heart disease. This is the #1 killer of the Romanian people. Although cancer mortality is on the rise also, Romania is also faces challenges in controlling some infectious disease. We have the highest rate of tuberculosis cases, unfortunately, but #1 killer is ischemic heart disease, and then the cancer, colorectal cancer is growing in the latest years, very, very crazy.
Mm-hmm.
What I'd also like to add, and what for me is very interesting, is that when I was looking at the stats for Romania, we're actually in the top 10 countries in Europe for worst heart disease. So we have lots of high numbers, and I'm ethnically a Hungarian in Transylvania, in the Transylvanian region of Romania. There's over 1 million Hungarians living, and I was also looking at the stats for Hungary, and Hungary and Romania are right next to each other in Europe for some of the worst heart disease. And part of the reason for that, as a dietitian, what I see is it's the traditional diet that both Hungarians and Romanians have, which has some overlap and some similarity, since we've been, neighbors and obviously living in the same country in Transylvania for a good while. And it's just amazing to me how, if we look at certain diets in Europe, for example, where there's a much higher intake of, let's say, salad or fruits, or what people would nowadays, I guess, more fashionably refer to as the Mediterranean diet. When we look at those countries, they're way lower on the list than we are. And even though many Romanians still eat home cooked food, and we still have such high rates of heart disease, it means that our traditional home cooking has a problem with it. For us, I think #1 for us, it's not the eating out. It's not the rest. It's also the restaurant food, don't get me wrong, but there's also problems at the foundation of how people cook at home.
Mm. Now, if I talked to you one time, and you mentioned to me, Konrád, that in Romania, pork is considered to be a vegetable.
Yeah, that's a joke.
I mean, that was a joke, right?
Right. That's a joke I've heard a number of times while I've been living here in Romania. They say the best vegetable is pork.
So meat consumption is part of the culture then, in a fairly prominent manner, right?
Right. Pork is basically one of the most staple meats, I would say, in Romania, both for Romanians and Hungarians. And because Romania is still a more agricultural country, more kind of traditional agriculture as compared to many Western European countries, here many people still raise their own animals, and so they will raise 1 or 2 or 3 pigs a year, which they will then slaughter very often around Christmas time, because the traditional Christmas meat in Romania is pork.
So it becomes a staple then.
Yeah.
Yeah.
And lately, the very well-known nutritionists and doctors are promoting this pork, and somehow people are confused because they know the meat from the pig is very grassy and not good because the high levels of hem iron. But then the TV, the medical doctors and nutritionists are coming and say, eat this steak or this pork piece because it's good. So people are very confused, and that is very a serious problem for us, because we are trying to educate, but then people are getting confused and they don't know how to put it on the table, you know.
Mm-hmm. So it sounds like public education and motivation is becoming a very big issue then, as it is in every country, really, but particularly in your situation there. So, you know, I was reading that the Romanian death rate from cardiovascular disease is 3 times the rate that we have in America. And we don't look too good either, right? So this seems to be a very, very major thing. And it's interesting that you mentioned that as you are a physician working in an ambulance service, you see a lot of deaths, and they're usually not accidents, but they're usually cardiovascular disease. Is that right?
Yes, and unfortunately, this is coming at a younger age than before, and it's very frequently for us to have the young patients with strokes or hypertension, and even heart attack is so sad. Is happening this at beginning, starting with a younger age than before. So it's getting worse, I think.
Just want to interrupt and say that Dr. Lawson earlier on wanted to say something. So I saw you had your hand up. We don't want to pass over.
I've used my reaction, my little hand up in the corner. I'll get rid of it now. I'll take it away. No, I just wanted to come in because you know, life is a lot more complicated than perhaps these discussions are taking on. I think that worldwide, you know, globally, there's something like 1 billion people live in extreme poverty. Now, in Romania, 1/4 of your population live in relative poverty. Now, if we're asking people to make changes, and lifestyle medicine is effectively about behavioral change, then they have to be in the right environment to make that change. And part of what lifestyle medicine must offer is to have that breadth and the depth of evidence, but have the breadth of approach, so that we can make changes, as we say in this country, #1 change at a time. I think behavioral change is key. And I think that, you know, we cannot, you know, I don't know, I don't want to hijack this, but as a general practitioner, incidentally just retired 2 months ago from clinical practice, there are certain traits, if you like, that the average doctor needs to have. And that's they've got to be a theorist, they've got to be an activist, they've got to be a reflector, and they've got to be a pragmatist. And the question is, well, depending on what kind of doctor you are, which do you major on? And in order to be an effective doctor, or even a healthcare worker, in my opinion, you have to be a pragmatist. You have all of these traits, but you also have to be a pragmatist. So what matters is the patient in front of us, not what we believe, but what they believe, what matters to them. So that the behavioral change starts at that intersection, if you like. So I think that we mustn't forget that is, you know, in Romania, you've got people who drink a lot, you've got people who smoke a lot. We've got to think, well, why do they drink a lot? And why do they smoke a lot? And then how do I address the problems that they are alleviating by smoking too much or drinking too much? So it's not, I don't think, a matter of education. I think that almost everybody you ask will know that smoking is not good for you and drinking excess alcohol is not good for you. So sorry for that interruption, Hans.
No, it's okay. It's okay. We have a dialogue here. You know, I remember Karelia in Finland. Do you remember the highest rate of heart disease in the world at the time? Finland, Karelia, right close to the Russian border. And a young epidemiologist began to analyze the situation, and he thought it was probably related to dietary factors. He made some proposals. He was cut down by his medical colleagues. They thought of him as a young whippersnapper that didn't really know too much about the real issues of medicine, but he was strong. And the women would come to him and would say, we don't want to become widows. These people were 35, 42 years of age, these women. And it was called the country of beautiful widows, because they died young because of the husbands. And these were lumberjacks usually. And so he began to make some changes with the support of the government, and they introduced now different kinds of foods. They replaced the salt content with a different kind of salt that didn't have the sodium in it. They began to emphasize to cut back on animal products, the saturated fats. They began to bring fruits and vegetables into the country, which was not easily grown in Finland, where you have 6-7 months winter, right? So, and what happens is that 80% of the death rates was diminished over the next 25 years. So, I mean, it's not just on the individual basis. Yes, of course it is, but it also, we need to have, I think, a support, an awareness campaign that filters throughout the society, through the media and so on. So I think we have to probably work both sides. Would you be comfortable with that? Yeah. So I appreciate that. Yeah.
I'd like to add something with which, you know, to what Dr. Lawson said. You know, I'm sympathetic to that, because we see all kind of people coming to Hergelia, and we realize that there is not one message which fits everybody. There may be some areas in Romania where the best food is eggs and milk, because, you know, they don't have access to others and they grow them right there in their agriculture is a self-sustaining agriculture, which is becoming very rare in the world. So I think we need to be very sensitive to from where the people come, what kind of background, what's their environment, what access do they have to these, and I really like the concept you presented. I've seen with this continuum of diet. It's not, you know, black and white. It's a continuum, and maybe for some of the people, it's best to be on the left side, not on the right side.
Yes.
I can just interrupt for 1 second as well with something that came to mind when Dr. Lawson was speaking. With regards to behavior change, and also what Dr. Dan was saying about sensitivity to the needs of the patient, as a coach, as a lifestyle coach, and having worked with people doing coaching, it's a very powerful tool that we can use to help people in the direction of behavior change. And I bring it in here because, I mean, you mentioned it in your presentation this afternoon as well, Dr. Lawson, about coaching, coaxing. Well, you had a whole list of different techniques, but I actually think that many doctors in Romania haven't heard of coaching yet. And if they have, they might think it's some form of charlatanism. And I actually see the power of coaching. And I was reading one of the textbooks of lifestyle medicine just a few weeks ago, and they have a whole chapter on the importance of these techniques like coaching, where they're non-aggressive ways to get to the root of the problem, to help the patient go through periods of reflection when they can really start to analyze why they do what they do.
No, I think this is very, very good counsel. How we approach it is very, 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 very important. We are trying to help people to develop from within the desire, and from within, out of the knowledge base that becomes established, a desire to making some of these changes. And I think, you know, like Dr. Dan is saying, we need to be very, very adaptable. I mean, I cannot go to Alaska and tell people to eat more fruits and vegetables and don't eat that moose. You've got to work with the things that you have. And so I think adaptability is a very, very key issue, and also delivering the message with great care and a loving concern. This is not dictating some new guidelines. This is what we're going to do from now. No. It has to be done. Like you said, behavior change has to come from within.
And probably I should
some. Oh, sorry.
Probably I just should add to that lifestyle medicine and coming to a place like Hergelia gives to the patients a map. And they through coaching they are helped to know where they are, what's the best decision for where they are, but they have the map. They know that there is a more ideal place where they can reach with greater benefits. So it's such a difference between a person who has a map and somebody who is wandering around without a map.
Yes, but I think the most important things here is for our patients is to encourage them and to be a role model as a doctor for them. I remember I was at Banner Medical Center and shadowing Dr. LOOMIS. I remember all his medals from ultramarathon, Ironman, and all the medals on the wall, inspiring so many patients of him. And when he was talking with the athletes, he was showing his story, his personal story, starting from one point. And this, I think, combined with so many instruments of coaching, indeed, we can make a change, a real change for our patient. But I would like to ask dear Dr. LOOMIS to tell us more about how is to train or to educate the athletes, because I'm very interested. I'm a football team doctor in weekends, and I have a team of boys that adores meat, and I cannot make them understand what is important for recovering and reinforcing their energy. Please let us know what are your secrets. I know them, but I would like the public to.
Yeah, thank you. Thank you for your kind words. Well, first of all, just to back up for a second, I just want to make a quick comment on some of the things we were just talking about and build on what Dr. Lawson was saying. I've come to realize that, in medical school, so I call it first, second, and third order thinking, right? So in medical school, what I really learned was first, what we all learned, I think, was what I call first order thinking. Patient comes in, their blood pressure's high. We might have a discussion about lifestyle in the old days, before I learned personally the power of lifestyle medicine, about lifestyle, but literally it'd be one sentence, right? Your blood pressure is high. You need to cut back on your salt, exercise more, lose some weight. But implicit in my message was, I know you can't do that, so I'm going to put you on this pill, right? And then we kind of evolved into what I call second order thinking. Your blood pressure is high and it looks like you eat too much salt, so eat less salt, right? And we're pretty good at that. Not great, but pretty good. But where we rarely go is asking to the third order. And that's asking, why do you eat too much salt? And that's what I think what Dr. Lawson was kind of alluding to, that if the reason you eat too much salt is you're unhappy in a marital situation or unhappy at work, and you stay up late watching TV, eating salted popcorn because you don't want to, get in bed with your spouse. The answer is not less salt, and the answer is not necessarily pills. The answer is understanding what the emotional drivers are of your dietary choices, and that's really the power of coaching. It really is trying to peel back the layers of the onion till you really get to root cause, which. And on the surface, we think, oh, it's too much salt in the diet, but that may not necessarily be the truth, that is not necessarily the root cause. And so, again, that's one of the, we don't need any more research on the best diet to prevent, treat, and reverse type 2 diabetes. What we need research on is how you help patients manage behavioral change, right? That's really the key, and coaching and cognitive behavioral therapy, motivational interviewing, all those things play into that, I think. Back to the athlete question, as some of you may know, I was featured in the documentary The Game Changers, which came out a year or two ago, and which really gets to the core part of what in what you were talking about. Is it's really about overcoming this mythology in the sports world, what we call bro science, around, I have to eat meat to get protein and be strong and be fast and on, and really trying to dispel that myth. And so oftentimes I start when I talk to athletes, I can share my own personal experience that, I didn't know what eating healthy was. I used to be a marathon runner in med school. And, my idea of healthy eating was low fat, dairy and lean meat and, not too much ice cream. And unfortunately found out that I couldn't literally outrun that. After a knee injury about 10 years ago, I stopped exercising, gained a lot of weight, developed a number of chronic health issues. I actually went into AFib and turned out I had untreated sleep apnea and my cholesterol's through the roof. And I'm starting to collect doctors and they're treating me just like I treated my patients. Drugs and CPAP machine and on and on. And then I stumbled across forks over knives and thought, wow, food is medicine. How come I didn't learn that in med school? Transitioned to a plant-based diet, rehabbed my knee, and over the course of a few months, lost 40, 50 pounds, 20, 30 kilos, dropped my cholesterol 100 points, reversed all of my chronic problems. And at age 60, wanted to do something epic and trained for and completed a full Ironman triathlon. All on plants. And so first of all, storytelling is a very important part of how we communicate and being able to tell that story to my patients, whether they're athletes or not, because I think we forget sometimes that, we evolve, as I mentioned in my presentation, we evolve to be physically active, right? We're all athletes. Now, some of us are more athletic than others, right? But when you carry your groceries in from the car or the laundry up from the basement, or you give your kids a piggyback ride, or you're kicking a football around the backyard, you're being athletic. And so there's no one special diet. There's some nuances, if you're an ultra endurance athlete, there's some nuances in the diet, or if you're an Olympic weightlifter, but fundamentally it's all the same thing. And again, when I'm trying to counsel athletes, I can tell my story. I can point them to the documentary Game Changer, which is completely evidence-based. I was incredibly impressed with the way that Luis Hoyos and James Wilkes, every statement I made in that film, I sent the scientific references to support whatever information I provided. And those references are now available on the website and such as that. And so, I just tell patients, just try it. I mean, just patients or athletes, just give this a try for 2 or 3 weeks, 4 weeks. Most patients, most athletes feel so much better. They recover faster that you don't have to sell it any further than that because of the profound difference, especially the difference on athletic recovery from physical activity is where it really is so profound. So I'll be quiet now.
You brought a very good point in that the fact that you have been there, you have gone through these situations, and now you can share that, and you have the medals on your wall. I mean, that's credibility for what you're going to suggest to them, right?
Right. No, that's right. And if you look at the research, I mean, there's lots of research around this, around nutrition research. 94%, I think, of physicians know that nutrition is important. Only 4% in the United States feel qualified to talk about it. We know that physicians who don't practice a healthy lifestyle, that don't exercise, that don't cook healthy, that don't eat healthy, that don't get a good night's sleep, that smoke or drink too much alcohol, don't counsel their patients on those behaviors. So in fact, we do in fact need to heal ourselves first, right? Because if we don't believe, if we don't practice, if we don't walk the walk, right? People aren't going to listen to you as nearly as well as when you talk the talk, right? As they say. So it's very important. And one of the more interesting pieces of research I saw recently was, when physicians are obese, for example, there's clear evidence that they lose credibility. Patients are much less likely to follow the direction, the advice they give. They're less likely to get prescriptions filled, on and on and on. So physician obesity changes the perception of the patient to the physician. But what's interesting is some recent research suggests that the corollary is also true. So if a physician is obese and weighs more, has a BMI greater than the patient, the diagnosis of obesity only shows up in the chart, in the medical record, about 3 or 4% of the time. When the physician weighs less than the patient, it shows up about 95% of the time. So not only does our own personal lifestyle and health influence the way patients perceive us, it changes the way we perceive our patients. And if, you know, if you don't feel obesity is a problem that needs to be addressed, guess what? It doesn't get addressed. And so, you know, we talk a lot about these, you know, lifestyle medicine to help our patients improve their health. But one thing I think we overlook is that, you know, it's also good for us as healthcare providers. And it's incredibly important because, again, us being able to tell those stories and share the steps we've taken to improve our own personal health really help motivate and create credibility to the patients.
Yeah, to summarize what you have said, it seems to me that the cultural transformation has to include the physician as a role model.
That's exactly right.
Yes, I believe that too, that the first step of changing is to educate and empower the leaders, because people will follow them. And in Romania, we as doctors, we have such a big credibility in the people's eyes still. And if they are coming to you and you will tell them the pork is the best vegetable, they will follow your advices. So that's why we have, I feel it, we have to educate the physician and the professional, medical professionals in Romania first regarding the healthy eating, the lifestyle medicine interventions, because if they will be educated, they will try to educate the people and the patients around them. Yeah, thank you so much, Dr. Loomis, for reminding me all this good how to say, tips of dealing with lifestyle intervention. I'm very nostalgic about the internship I had at the Barnan Medical Center. Thank you so much.
All right,
you are my role model.
Yeah,
thank you.
I just want to remind all the panel members that we're talking a lot about physicians, but this Congress, I was actually speaking to someone and they were a bit confused. What do you mean it's a Congress that's not like specifically for one segment? This Congress is for everyone who's a health professional. And so when we say physicians, to the audience, I'd like to remind you that we're not talking just about doctors. I mean, we're mostly doctors on the panel, but we're talking about whether you're a dietitian, a dentist, a pharmacist, a physiotherapist, it doesn't matter. You still have to be a role model, and you have to show what people should be doing. There's also one other thing that reminded me of something very interesting, a concept which I've met more with in the last few years. It reminded me, based on what Dr. Loomis said, the idea of the doctor actually having to become, at the same time, not just a doctor. It's about, you know, if you have to get down to the root cause, you also have to be kind of a little bit, at least, of a psychologist, and you have to be a little bit, at least, of a family counselor. And I'm gonna be quite radical with this, because I actually heard this at the Congress about 5 or 6 years ago, and it left me gobsmacked. Many patients actually look to their doctors even for spiritual support. Like that for me I was very surprised. And that's interesting for me, because what I learned when I was going through medical training was the doctor's the doctor. You deal with the body, you leave the spiritual side to the priest or the guru or whatever. You leave the psychological side to the psychologist, and you leave the counseling to the family therapist, and so on and so forth. What do you guys think about this? Because it's pretty different to what most of us learn.
You are proposing here a holistic concept of patient care, not just the physical, but also the social and the spiritual as well.
Well, yeah, I mean, the word we use is holistic, but it's very radical, because it suddenly puts you as a physician into a position where you realize that you've learned for 6 years and it's nowhere near enough. You got to start reading psychology. You got to start reading counseling techniques and a whole bunch of stuff that you don't know and you've never learned.
Can I come in?
Yes, of course.
You know, I've had plenty of time to reflect on my time in medicine. I'm now an old fossil. I'm a has-been doctor. I'm finished and washed up. But you end up thinking, well, what have I done in all this time? And the sad truth is that I've contributed to the worsening of the health of my country. Not willingly, not knowingly, but that is the fact. Now, at individual level, as a doctor, I think...
No, wait. That's pretty tough language there. Can you explain that a little bit more?
Yeah, well, healthy life expectancy, for example, has worsened. The disparity between rich and poor has widened. The life nowadays, of course, healthy life expectancy itself is stalled and is going down. So, right. So that the fact that my now 6-year-old grandchild has a lesser healthy life expectancy than his father is something that our generation should be very unproud of, put it mildly. So I think that's one of the issues. But to get back to the spiritual bit, that I concluded that it was often not what I did to the patient that made them better or helped them on their journey. It was simply the fact that they trusted me. Mm-hmm. They trusted me. And it's a trust between you as a doctor or a healthcare worker and the patient that played a huge impact on the benefit of that relationship. And that's why I think lifestyle medicine has a big part to play, because that, I believe 95% of lifestyle medicine is this, the psychology and behavioral change. And so we should be being taught behavioral science at university, not just nutrition. We don't get taught nutrition anyway, but you take my point, that there's this wider dimension that I think that you are making about spirituality. We know that the Harvard Adult Development Study and also the longevity study, when they looked at what made people live a long time, it was having purpose in life, it was having someone to share it with, it was being involved in a local community. It had nothing to do with cholesterol, it had nothing to do with blood pressure, it had nothing to do with, So there's this holistic approach puts us as physicians and healthcare workers in a very strong position to help people at individual level. But at individual level, we have to look beyond, upstream at the causes of ill health. And that's where I think that the lifestyle medicine has to have that breadth of vision if we're really going to make a difference at population level.
What I'm picking up here is that you folks are really looking for a new educational concept of physicians. I mean, the physician basically is just giving orders. I want you to stop smoking, lose weight, do this, do this, do this. But it has to be taking place, number one, in a caring environment. It has to be done in such a way that we create some support structures so the patient is not all by himself or herself. And I think this whole concept of multiple medical appointments, group appointments, might be just one of these things that we could perhaps utilize, isn't it?
Yeah, I mean, I would agree with that. I think that, as physicians, especially in the United States, where the way the medical system kind of runs and the reimbursement systems and things like that, we are kind of, there is a time constraint about the amount of time we can spend with patients. And I think, I think to Dr. Lawson's point, I think teaching physicians motivational interviewing and things like that to unsurface kind of what some of these social and emotional determinants of health are, and then building a team, a care team around that, health coaches, dietitians, exercise specialists, psychologists to deal with the more severe emotional eating addictions, things like that. So that our role becomes, we get to that third level, we get to that third order thinking we're talking about, and then depending on what those drivers are, whether it be concerns about my finances, or I lack a social support system, or I don't know what quinoa is, and I don't know how to cook healthy. So developing a toolkit within the practice to really help guide the patient, depending on what those third order issues are, so that the physician doesn't, doing all this, it's really not practical, at least in our setting, to take all of that on. But certainly being trained to again, through motivational interviewing and things like that, to sort out what the issues are and then have a team approach. We have found great success in group visits, by the way, because then the patients become self-supporting. Those are often run by our nurse practitioner or even dietitians, so that they can group problem solve, because in that group, whatever issue it is, I can almost guarantee someone else in the group has the same issue and someone else has probably found some solutions to those issues. So I agree that group visits are certainly one part of that toolkit.
Jim, can I come in for a second? Can I come in there? That's, I can't agree more on the what you call group visits. We call or shared medical appointments in the States. It was, as Ed Nofsinger has started off, we call them group consultations over here. But one of the criticisms of lifestyle medicine in this part of the world is perceived as a very middle-class pastime. It's a niche thing, which of course it isn't. And I think it's immensely patronizing to people from poor socioeconomic backgrounds to even mention that. Now, what we're finding is that we are reaching the people that need it most through the process of group consultations or shared medical appointments. And I think your other point about the team approach is huge. We as lifestyle medicine physicians cannot act on our own. We have to have a team around us and be part of that team, not necessarily the leader of the team, but part of it. And I think that, so over here, your supported behavioral change is the key. And so you have to have the team around you to enable that. And in that context of a group visit, as you call it, I think that is a great future. If you like, it's an entree for lifestyle medicine into our country, which of course is free at the point of delivery for healthcare, and it gets to the people that need it the most. It is lifestyle medicine is not about the worried well. It's not about the middle classes who want to talk about quinoa and avocado and squash. It's much more basic than that.
No, I agree. Behavior.
Yes.
No, when I discuss behavior change with patients and talk to them about, it is hard because, many of our eating habits, for example, are learned behaviors. Our trigger, what triggers us start eating, stop eating, environmental triggers, emotional triggers, that stuff we learned a long time ago. And relearning that can be difficult. And the analogy I use, it's like pushing a snowball over the top of a mountain, right? And so there's 3 steps people have to go through. And having been through this myself, I can speak to it. The first is we have to give our patients a reason to push that snowball to the top of the mountain so it can get over the other side. Because once it does, you start to lose weight, they feel better, they're off the drugs, everything just builds on itself. The hard part's getting the snowball to the top, and some people's mountains are really tall and the road's really steep. So first of all, we have to give them purpose. And we as physicians, I think, sometimes come at this the wrong way because we use fear, right? Quit smoking, you're going to get cancer. Get your cholesterol down, you're going to have a heart attack. Get your blood pressure down, you're going to have a smoke. Or you're going to have a stroke. People know that, right? But it doesn't motivate change over the long run. So a different way to frame purpose is, why would it be important for you not to have these bad things happen to you? And the answers to all of those are the same. For my kids, my grandkids, my retirement, whatever. Second of all, it's helping them lower the slope of the road and the height of the mountain. And that's systematically and honestly asking the questions, what's going to make this hard? What are your barriers to change? And again, that's kind of the motivational interviewing part. And then developing, again, that toolkit to plug them in depending on what those barriers are. And then lastly, and again, back to what Dr. Lawson said about longevity, the last thing is patients have to do is recruit as many people as they can to help them push that snowball, because change is hard. And we all know the importance of social networks around change. And so whether it be friends, family members, groups, online, group visits, group programs, whatever. If you can bring all of those things together, help the patients with the support system, with the tools they need to overcome the barriers and help them frame purpose, I think the success rate, of that 3 to 6 months it typically takes to institute change is much greater, we found, when we really take this almost systematic approach to understanding what's driving their current behavior and how to educate the patients about how to make healthful change that sticks over the long run.
So what I'm hearing you folks are saying, as I'm summarizing my portion and turn it back over to the chairperson here, lifestyle medicine has some of these tools in place, it has these concepts in place that you don't find in traditional academic medicine. And so maybe having discussed some of the reasons why we have these diseases, why we have shorter life expectancy, maybe we have to begin to think about a cultural transformation. But that cultural transformation is not going to come from physicians who are not being exposed to these kind of things in medical school, right? So maybe that's where lifestyle medicine can really make a significant contribution in not only bringing the behaviors together and the skill development, but doing it in a group process where, as you said, you're no longer by yourself. You're supported. You feel you can do it. You find answers among yourselves. And the physician then, the health provider, becomes a facilitator of the process rather than being the dictator.
Yeah.
Does it sound okay?
Yeah, yeah. It's very different to what we learned. And you know, I don't know if you want to say more, if I can start to transition into the questions, because we actually have a question similar to this. So if that's okay, somebody actually asked us about lifestyle medicine education, and I'm just looking for the question just now to read it to you. It says, do you consider implementing lifestyle medicine in medical schools? It would be great to have it in the curriculum. Now, probably some of you can talk about the master's program in Lithuania, which I wish we had a little bit more data on, but if we've had the question, anybody who'd like to get more of an education in lifestyle medicine until all medical schools include it, you know, in their normal curriculum, please tell us a little bit about the lifestyle medicine master's degree in Lithuania.
Well, you know, if you wait for medical schools to make the changes along the lines of lifestyle medicine, I think I'm a very big pessimist that will happen. And so when I went to Lithuania at the invitation of a leader in the society there, I went to the School of Medicine, and I had just given a presentation in New York about the importance of lifestyle medicine, preventive medicine, reversing disease, cultural change, the physician as a coach and as a, you know, let's say, the quarterback using a team. I went to the dean of the medical school, and he said to me, what do you want to do? You want to, I mean, your emphasis on reversing disease through some new concepts of behavioral change, psychology. And he looked at me and he said, I don't think that fits into our economic objectives as physicians. So I went to the president of the university, and I said, and he was an epidemiologist prior to that. And I said, I'm coming from an epidemiological viewpoint. I've done some work with group process, and we have had some fairly significant clinical breakthroughs. We published some 30, 40 papers. And he said to me, oh, no, you have to go to see the dean of the public health program. And so they began to roll things forward now. And ultimately, it became a master's degree in lifestyle medicine. It's a 1.5-year program. People, for their master's thesis, they have to do an actual program where they actually implement what they have learned. It focuses largely on nutritional therapy, therapeutic nutrition, exercise, enough sleep, all the things that we talk about in lifestyle medicine, those 6 elements. And the dean, of course, was a bit concerned. She said, if we really now promote this new program and people get a master's degree, how do they find a job? Where do they find a job? And again, this all began to gradually change. They've had annual conferences like what you're doing right now in Romania, and the understanding was growing. The media picked up some of these ideas, and people began to talk about it. And today you see the 5th graduating class, and they're okay in finding jobs it's an emergence of a new concept that people begin to realize we need to embrace if you want to turn this disease around. Because, you know, Lithuania is very close to Romania in life expectancy. You're sort of neck to neck. And it all happened largely because when the Russians were kicked out in 1989, the West came in with all their goodies, with all their foods, with all their pornography and everything else, everything good and everything debatable good. And, you know, now they're trying to find their own roots again, where they had been in the past, and to find a new resolution to solve these issues.
Thank you very much.
I really like to recommend the program. It's an online program. It's in English, good results, and it's very affordable.
I've shared my screen for any of you who are interested.
Yeah.
It's the Lifestyle Medicine University program at in the city of Kaunas in Lithuania. It's an English language program, so you don't have to know the local language. You can go from any country if you speak English. Dr. Lawson, I see you have your hand up.
I do. Two things, if I have time. One is to pick up on this being a good example as physicians or healthcare workers, that ultimately I also said that we couldn't work independently. And so in order to achieve supported behavior change, we have a system called link workers who come from the communities in which we serve. So if you can get good examples within your community, then that will actually be a more powerful message than you yourself as a clinician. In other words, the experience of your patient will be a much more powerful story than your own. That's the first part. The second part, I'm not nearly as pessimistic as Hans, because in the UK, a number of universities are now introducing lifestyle medicine into the curriculum. It has been one of our main pointers, if you like, to get it into undergraduate education. So it is happening. And secondly, thirdly, we can't let this go by without saying that the International Board of Lifestyle Medicine, of course, does have a diploma certification program. And naturally, we support it at global level and European level as well. And that gives people, if you like, the standard, it gives the credibility to be able to bring it to their practice. And so I'd recommend that as well.
Excellent. Thank you very much. Yes, for everybody who's listening, if you are interested, there are things happening worldwide. Maybe you haven't seen it happening in Romania, but there are things happening. You can get further training. There are institutions and opportunities. So if any of you are doctors and you'd like to get the subspecialty, I guess I would say, of lifestyle, you can get that. There's, you know, the International Board of Lifestyle Medicine can help you with that, with getting accredited and so.
Well, I just want to add this. I just want to add. Yeah. Okay.
Sorry, I wanted to remember that you have, for the first time in Romania, training local at Hergelia clinic for the new nurses, and this is quite a thing. So Hergelia is training the nurses in lifestyle care. Isn't that right, Dr.
Yeah, yes, we are starting state license, 3 years, fully licensed program. And of course, the nurses will learn everything which they learn, in conventional medicine, but additionally, they will learn lifestyle medicine nursing. And, we are very excited about that. And one point, I'm siding with Dr. Lawson about optimist. I'm a very optimistic person. And, in Israel, I met a lady, I'm so sorry, she's part of the lifestyle movement. And she's a family practitioner, and she was able to convince 3 of the medical schools in Israel to implement a 6-month course in lifestyle medicine, which is, it's a beginning step, but that was great.
Yeah. Definitely. Okay, we have a lot of questions that have come in, and so I'd like to move on to the next question. We have a lot of questions that gravitate around lipids, triglycerides, paleo diet. So let's take some of these questions. I'm going to try and condense maybe some of the questions into one question. One of the questions that I've been seeing repeated on what's been coming in is, can you please clarify the role of vegetable oil in raising cholesterol levels? How does that happen? And especially if some of you can explain some of the biochemistry behind that.
So I can speak to that brief. Now, I'm just a disclaimer, I'm not a lipidologist or cardiologist, but so it's my understanding that there's two reasons that vegetable oils raise LDL cholesterol. So trans fats consumption, which can be created so oils have a smoke point, and when you cook food with oil at a high heat, especially some of the oils that have a lower smoke point, they get converted to trans fats, and trans fats can directly increase cholesterol synthesis in the liver. But probably more importantly, for the majority, seems to be not a direct effect of cholesterol synthesis. It has to do with downregulation of the LDL receptor. And so when we consume a high-fat diet and we see increased intrahepatic triglyceride or fat, that triggers a downregulation of LDL receptors, so the liver can't take up and remetabolize the LDL that's circulating in our bloodstream. So it's actually it's a combination of increased synthesis, mainly through trans fats, and a downregulation of LDL receptors, which seems to be the majority of the association of increased LDL.
And this downregulation is caused specifically by which component? Is it the saturated fat? It's
saturated fat primarily.
Okay, and does it matter how long the carbon chain is? Are we talking long chain saturated fats, or are the medium chain, the short chain going to do the same thing?
It's mainly the longer chain, I believe, although I can't answer that 100%.
I saw Dr. DIEHL was saying something, but it didn't come through. What were you saying there, Dr. DIEHL?
Well, it's mostly the medium and long chain fatty acids.
Okay, and then this actually connects with another question I have with coconut oil, because coconut oil was promoted as being a better source of fat because it has medium chain saturated fats, not long
and
chain.
short chain too.
Medium, yeah.
I mean, this is a great marketing story. What the coconut industry has done. Coconuts can be grown very cheaply. They're harvested very cheaply in Malaysia, and so they have a big profit margin, and they know exactly how to use it. Here's a clean-looking, white-looking, nature-looking product, and people come to me and they say, I just bought 5 gallons of coconut oil from Costco, and you're telling me this is not the way to go. I said, well, I'm sorry to tell you this, but the American Heart Association had a big meeting on this, and their recommendation is, we recommend coconut oil, but only use it on your skin or your scalp. Don't put it into your mouth.
Yeah.
Because, the saturation, just to give you some orientation there, when you look at olive oil, it's about 15% saturation. When you look at beef fat, it's about 50% saturation. If you look at palm oil, 78% saturation. When you look at coconut oil, 92.5% saturation. Nothing drives the synthesis rate in the liver faster than coconut oil.
Okay, and you mentioned olive oil, so I'm going to throw in the next question, which has to do with olive oil. Somebody's asking, okay, in terms of saturated fat, then, is olive oil the best option of all, and is it okay in moderate amounts? That's the first part of the question. Let's focus on that, and then there's a very important second part of the question, which I want to follow up with. So, olive oil, is that the best option? Should we be using it?
Well, again, it depends on the setting that you're in. If you're in America, there is no good fat, period. Because regardless whether it is, quotes, a good fat or not so ideal fat, Every fat has 9 calories. And in America, where 74% of the population is overweight and obese, you cannot really recommend oils, an extracted product from an olive. Just like there's a difference between eating a coconut versus extracting the oil from it, because you concentrate it and you also lose some of the nutritional value. So I think when it comes to a society where you have obesity, I think we should be very, very careful with any kind of oil because of the obesity aspect. Now, in Romania, you don't have the obesity problem yet, from what I understand. It's coming.
It's coming.
It's
yes,
coming.
but we have a very high rates of obesity in kids and kids section. So it is quite a problem.
Yeah, but in the adult population, it's not quite as rampant as what we have in America. So, you know, I think from the point of view of obesity management, I think we should be very, very careful with any kind of fat. It's an extracted product. It's an industrialized product. It doesn't come like that in nature. And so that brings me now to your second point that you want to make.
Can I build on that real quick?
Loomis wants to say something.
Yeah. So just along those same lines, the other place, you know, when 66% of the U.S. population has prediabetes or diabetes, it's equally as important, because we know that the root cause of insulin resistance is increased intramuscular and intrahepatic triglyceride. The other thing about that I think—
Can I just interrupt you there for a second, Dr. Loomis? Just in case somebody missed that, can you please repeat what you just said about what drives insulin resistance? Because it's so counter to what we're hearing most of the time.
No, that's exactly right. So you know, what when I talk about type 2 diabetes or prediabetes with my patients, I like to use the kitchen sink model, right? So imagine a patient walks into their kitchen this morning and the sink was clogged, you left the water running overnight, and there's water on the floor, right? So how do you fix that problem? You get a mop out and mop up the water, and one mop's maybe not strong. If you get another mop, you get a third mop, you finally get the water up, you put your mops away. Well, guess what? You come back later today or tomorrow, the water's back on the floor because you haven't really fixed the problem. That's exactly how we were taught to treat type 2 diabetes, right? We get out a metformin mop, and then we might add a Januvia mop, we might add some insulin, put our mops away. That's not the problem. The problem is the drain's clogged and the water's running, right? So what's clogging the drain? It's fat deposited in the muscle and liver cells, which makes those cells resistant to insulin. And the water is the highly processed foods, which are driving the need for insulin. And that's exactly why a low-fat, high-fiber, plant-strong diet, plant-based diet is such a powerful tool in the treatment, prevention, and reversal of type 2 diabetes. And prediabetes is the drain's clogged, the water's on, the sink just hasn't overflowed yet. And so, you know, one of the questions earlier you mentioned was about keto diet, right? So keto diets will in fact show short-term improvement in diabetic control, but the reason is it only takes care of half of that problem. A keto diet turns off the water, but it doesn't unclog the drain. And there's evidence, in fact, Dr. Barnard at PCRM, where I worked, they just published a big review on keto diets that addressed this very fact, and showed that most people can't sustain a ketogenic diet for a long period of time. When you refeed after a ketogenic diet, the insulin resistance actually becomes worse, because basically you're clogging the drain more, but because you turn the water off on a ketogen with a low carb diet, you'll see transient improvement in diabetic control. But over the long run, it's not sustainable. And actually, there's evidence it will actually raise LDL cholesterol because of the high fat diet. It'll actually make insulin resistance worse over the long run. And so the other thing I think we overlook when we talk about edible oils, vegetable oils, has to do with inflammation, mainly driven by the ratio of omega-6 to omega-3 fatty acids. So it's felt that the optimum ratio of omega-6 to omega-3 is probably in the 3 to 5 to 1 range. Western diet, you'll see 50 to 1 range. An unhealthy plant-based diet with a lot of oil, you'll see 20 to 30 range. Olive oil has a 13 to 2 omega-6, omega-3 fatty acid ratio, right? So that's way above that optimal kind of 3 to 5 to 1 range that we think about. And then the other thing when I talk to patients about oil is thinking about it through the lens of nutrient density. You know, when we have extra money, we want to invest it in our financial future. We're looking for a positive return on investment, ROI. Well, that's how we should think about calories, because every calorie we ingest is either an investment in your health future or it's not. If you have 100 calories to invest in the moment, you can invest it in olive oil or chicken breast or broccoli. What's the ROI for edible oils? Well, it's oil, it's fat, right? There's no fiber, there's no cancer-fighting phytonutrients, there's no potassium to bring your blood pressure down, etc. Same with animal foods, right? It's just protein and fat, because those animals have served as middleman and used all the good stuff, the fiber and the phytonutrients, to run their own machinery. And in an ancestral diet, when we were starved for calories and trying to hang around long enough before we died of some infectious disease, there was probably a survival advantage to having that. But in the modern world, with the prevalence of these lifestyle foodborne illnesses, diabetes, high blood pressure, cholesterol, obesity, et cetera, maximizing the return on investment on your food is really the key. You get to broccoli, 100 calories of broccoli is 12 ounces. That's a lot of broccoli. There's almost as much protein as in an egg, right? 100 calories of olive oil is a tablespoon, five milliliters, right? So again, from a pure kind of, especially with epidemic, really obesity and type 2 diabetes really rising around the world, thinking about food through the lens of nutrient density, outside of the fact, is olive oil healthy or not, or edible oils in general, I think is another way to kind of reframe this dialogue.
Okay, thank you very much. I'm not sure, Dr. Lawson, did I kind of see that you wanted to say something during that discussion?
I'm always happy to say something. It may not be at all relevant to whatever you've been hearing. What I was thinking as you were speaking was the direct trial with run over here with Professor Roy Taylor, and he reported at our conference on that. But one of the take-home messages there was slightly to my surprise was that if, in terms of diabetes anyway, that whether you have a low carbohydrate diet or a low fat diet makes no difference. And if you basically diabetes, if you exceed your personal fat threshold and you have genetic predisposition, then you'll develop diabetes. And the surprising thing is, and Hans probably won't remember, but I talked about black swans in one of our previous meetings. And I think that one of the interesting things there is that 65% of people who are obese do not develop diabetes type 2. So we should be asking the question, why not? And how do we find them? And how do we find, the fat on the inside, thin on the inside, and the reverse? If we have an idea, scientifically proven, that we can personalize our approach, then I think we're on to a winner. I think it's really surprising to me that if you compare the waterfall chart between low carbohydrate and low fat, the outcomes are almost identical in terms of weight loss, but the range was also identical. So in some, people went up by 10 kilograms, others went down by 25 kilograms. And it was exactly the same in the other. So a personal, we're all different. That's the big message. We're all different. And I think we've got so much still to learn. That's the main lesson, I think.
Well, I'm sure that's true. But, we have over 100,000 graduates in our CHIP program. And we don't have carefully segmented, nuanced, different approaches to that. We have a basic approach to it, and it works just, magically. We instill not only a simpler diet, a daily exercise, stress management, supportive care, and so on, and it works very, very, very well. Now, coming back to the keto diet, we need to recognize the keto diet works very, very well. It's a very successful diet program. Yeah, short term only, because long term, what happens is that you actually, while you're successful short term, the first 6-7 months, you are actually mortgaging your long term health, because the diet will kick in the different direction.
Thank you. Those of you who haven't had the opportunity yet to look at the videos of they're on YouTube, you can find them, of the recommendations that were made to the board, to the council that was putting together the 2020-2025 dietary recommendations for the US. Have a look at them. They're very interesting. I'm saying to the participants, you'll find them on YouTube. They're a bit long, but they're very interesting, because what you'll find is that basically the discussion was split largely into two groups: people who are very much lobbying for plant-based and people who are very much lobbying for high fat, what we would call a ketogenic diet. So clearly these two directions at the moment are very prevalent, and people are interested, and I think some people are confused. So it's good for us to clarify what the risks are, short term and long term. And you're saying, Dr. DIEHL, that short term it has benefits, long term it doesn't. Do we have studies that support us in our discussion?
Oh yes, there are plenty of studies on that.
And what are they telling us long term?
In long term, you have to be concerned about atherosclerotic changes taking place. You have to be concerned about inflammatory processes taking over more and more.
And I just posted a link in the chat to the recent review article that was published in Frontiers of Nutrition about the long-term effects of keto diets. That was published out of our organization.
Thank you. For the participants, if you actually go to the YouTube channel of this live streaming, then I will forward that link for you there. You'll be able to find it, because the participants aren't actually on Zoom. We're streaming this from Zoom and it's on the platform. But if you go to the YouTube channel, then through the embed you find in the conference platform, you'll be able to find the link there in the chat. Okay, let's move on to another question. So we kind of talked about the fat aspect. The second half of that question that I was referring to earlier is someone's actually asking, and it's a very good question, that Dr. DIEHL, you spoke about nuts and seeds. Now anyone can answer this, not just Dr. DIEHL, anyone can answer. We talk about nuts and seeds a lot in the plant-based diet. Is it advised to avoid certain kinds of nuts and seeds in terms of quantity, or avoid them completely? If so, which ones and why?
Well, let me sort of just begin the discussion perhaps with us among ourselves here. Here at Loma Linda University, we have had research on the different kinds of nuts for the last 15 years. These results have been verified and vindicated in studies at Harvard University and so on. What we are finding is that nuts are very high calorically. I mean, a nut is 80% of the calories is fat. And so for many years, when there were low-fat advocates, they would always say, don't take any nuts. Nuts are not the ideal food if you want to lose weight. We have since then begun to understand more and more and more that nuts are being handled somewhat differently by the body. And somehow people can take some of these extra energy from nuts without harming themselves, as long as they keep it, at least that's the finding here, to about 1 ounce a day. When it comes to consuming nuts 5 days a week, 1 ounce, a small handful, they have actually shown that you can reduce coronary artery disease by 40%.
Okay. My question is, for example, what about pistachios? Because pistachios have a P2S ratio, a polyunsaturated fat to saturated fat ratio, which isn't so advantageous. So would we include, for example, pistachios in that list? Can we have those, or coconut, for example, coconut flakes?
Yeah, I don't think that we have looked at pistachios here at Loma Linda. So I don't have any answer for that.
Okay, so
walnuts, almonds.
Right, those are the ones. Dr. Loomis, you wanted to say something.
Yeah, so in my in our practice, you know, I mean, it's exactly true, obviously, that nuts are very high in fat, but I think, you know, I think nuts, we advocate nuts are okay within the context of a healthy overall diet, and especially patients that are obese or again have insulin resistance. We really try to get them to limit their fat intake to 30, 35 grams a day, somewhere in there. And so, you know, the problem with nuts is a few nuts go a long way within the context of limiting your fat intake, right? And avocados are kind of in that same group, right? So avocados, you know, nuts have about 2,000 calories per pound. Avocado is about 750 per pound. So there's nothing wrong with nuts. It's just in the context of, if you want to put a handful of walnuts on your oatmeal in the morning, there's health benefits from that. There probably is health benefits from that. If you want to eat a pound of walnuts a day as a snack, there's health consequences from that. And so I think, the discussion we typically have is not around, absolutes. It's around about relativity, if you will. And so as long as if you're consuming nuts or avocados or some of these higher fat, whole food, plant-based foods in the context of an overall healthy diet, again, limiting that in the 30, 35 gram range, then I think it's fine.
Okay, Doctor, thank you very much. And Dr. Lawson, I see that you'd like to.
Thank you very much. I'm not a nutritionist and not a scientist. I know nothing, but I understand that almonds are grown in the United States, and especially the Western United States, and an awful lot of water is used to grow them. So that's, in terms of planetary health and all the rest of it, there's that aspect of it. But on the other hand, one of the killers, if you like, in the modern 21st century is snacking, and especially the calorie dense and nutritionally bereft snacks that we have. If you take a handful of almonds, that would provide satiety or satiety. It would reduce the amount of snacking, perhaps. So I think that it complicates the picture to focus on any one particular nut or food or micronutrient or macronutrient, when actually you have to take the whole into consideration. So that's one of the curious things I learned during the International Board of Lifestyle Medicine course is that if you take 6 or 7 pistachios, it has a direct effect on your melatonin levels. So you sleep better at night.
There we go.
Who knew? Who knew?
Yeah. Thank you very much. For those of you struggling with insomnia, pistachios. There you go. I can add to that, there's a study on kiwis. 2 kiwis in the evening will extend sleep time in the morning by 1 hour. For those of you who are struggling, you're waking up too early. Thank you very much. And if you guys who are watching haven't noticed, Dr. Lawson brings us back to the idea of looking at everything holistically. So we can't focus on just one nut or one seed or one micro or macronutrient. It's not the magical omega-3 or the oat bran fad or whatever other fad has been along the way in the last 10, 20, 40, 50 years. It's the whole diet. And this is what the studies are showing, that, for example, even supplementing with vitamins and minerals doesn't actually decrease mortality. So if you're having a balanced diet, that's almost all you need. I say almost because if you are plant-based, you need to watch out for vitamin D and for vitamin B12. Now, I said the word plant-based, and we actually have a question, and I'm going to move forward to the next question. Someone's asking if you can please explain the difference, and I'd like to ask you very shortly to be succinct on this question, the difference between whole foods, plant-based, and vegan. Any of you?
Yeah, I can tackle that real quick. So, veganism historically comes from a place of compassion about not harming animals. So don't eat foods with animal products, don't use products tested on animals, don't wear products made from animals. Whole food plant-based is, depending on how you define it, is vegan. A true whole food plant-based diet is vegan in the sense there's no animal products, but it also eliminates all these highly processed foods. I think I talked about this in my presentation. So it eliminates the processed sugar and processed grains and processed oils and such as that. Now, there are some people that define whole food plant-based and people include small amounts of animal products. I don't personally, my view of whole food plant-based is vegan minus the processed foods. That's the way I view that. The way I define it, both in my own personal life, my own personal dietary patterns, and the way I discuss it with patients.
I like to sort of reinforce the idea that we have to look at dietary patterns rather than individual nutrients, right? We have to begin to realize that when you look at food, we need to think of a nutritional symphony where everything comes together, and where we also recognize what is the ecological impact, and we become more and more aware of some of these things. And I mean, we are, I think, on the right track in moving towards a whole food, plant-based diet. I think, Jim, you explained that very, very well.
Dr. Lawson, I see you want to say something.
Yes, I mean, I don't agree. I think that it's not what I understand to be plant-based at all. Veganism is a personal choice. It's an ideology. It's nothing to do with nutrition as far as we're concerned. It's lifestyle medicine is about whole food plant-based. Fine, let's call it plant-rich. But as for the reasons I explained before, that 97% of the population, you cannot become vegan overnight, nor should they. We have to deal with what's in front of us. And I think as a movement, to be painting ourselves into a vegan corner is entirely the wrong direction, in my opinion. So I think that's the main thing really that I want to get across, that ultimately, to get back to my earlier point, it's the person in front of us that matters, not our own personal beliefs. And we have to work with what's in front of us. Mm-hmm. And they're a long, long way from veganism. So I think that we have to pay attention to that.
Thank you very much. Emma, you want to say something?
Yeah, I think Romanian people are quite lucky because the most majority of us, we are Orthodox, we are Christian, and we have this fasting thing, putting together all the days of fasting. We are half a year fasting, so no animal products. The problem I am confronting with is the differences between the vegan and plant-based. Again, because some of the people are complaining, well, I'm fasting, I cannot feel good because, I don't know, something is missing, because they are eating a very monotone diet and a lot of processed, how to say, vegan food, and that's why they don't feel good. We have to promote this whole food plant-based, especially because in Romania we are still having this local grown foods. We have a lot of land is still worked by the villagers, and we have this local food that we can put on the table. So we have just to educate the Romanian to forget about the 30 years of fast food chain, them, and to go back to the roots and to eat more locally grown and whole food way in fasting times. So yes, it's there are plus and minuses. Pluses because we have this fasting periods, but minuses because after a communist system, people are feeling very eager to try everything they didn't have before. So we have 30 years of fast food, and already is a huge problem. I think we are going very quickly to the obesity rate we are seeing in the Western countries like United States. I've been there, I'm here, and okay, maybe in adults we don't have this big problem with obesity for now, but with kids it is a very big problem. So yeah, we should advise the parents. They should put more apples and more pears in the school bag instead of hamburger, Yeah, thank you. And I wanted to mention, just because we have a certain particularity in this country, being in the middle of influences, Eastern and Western. And I feel that Romanian tends to be more Western, oriented. So I'm afraid to not get to the obesity rate that you have in United States. So yeah.
Thank you very much. Now, unfortunately, our time is up. We actually have a lot more questions, and I feel bad because some of the questions are very pertinent and they're pathology orientated, and I would have loved to ask you them. And I have this burning desire to say, let's try and slot an extra Q&A session in somewhere in this program, but we'll see if it's doable. If anyone has any final remarks. Dr. Lawson, please.
Well, two final remarks. One is I think you have a presentation later from a lady from Japan. And I hope that one question that you put to her is that in the 50 years since Japan was at the bottom of the G7 table of health in terms of mortality, how it is now 50 years later, in that relatively short period of time, become the most healthy of the G7 countries? That would be a fascinating question, and the answer would be equally fascinating. And the second is to thank you and Konrád and everybody else for putting on such a great show in Romania, then to wish you well. And I think that as a consequence of these 3 or 4 days, your society will grow very quickly, and we want to do as much as we can to help you. So thank you very much for inviting me.
Thank you very much. And I'd like to also round off with just a few pieces of feedback from some of our listeners. Some of the things people sent in were not questions, they were actually comments. And I'd like to finish off with some really encouraging things that were sent in. One of our speakers actually, who will be speaking later on, has been following our Congress, Iuliu Ciupe-Vaida, a dietitian, and they wrote in what Dr. DIEHL, with regards to your presentations earlier on, what Dr. DIEHL says, wave after wave, is overwhelming. It's exactly what I've been saying to my patients for over a decade. I'm actually getting goosebumps on my arms from the emotions. I realize for the first time in my life that I'm not alone. This brings tears to my eyes. Thank you to all of you who made this possible. So I'd like to say thank you, especially to Emma, because she's done a colossal work to make this Congress happen. She says, the comment says in continuation, something like this in Romania, when I thought it would only happen in 20 or 30 years at the earliest. I am absolutely overwhelmed, moved. It's an amazing first stand. So hopefully we will be able to continue with all the positive input that the society is going to have in Romania. I also have another piece of feedback specifically for you, Dr. DIEHL. We have someone saying, congratulations, Professor DIEHL, marvelous presentation. So somebody really, I actually know who the person is who commented on this. It's the doctor, an angiologist in my area, and I was very pleased, very surprised that he's following along at the Congress. And one last comment says, first of all, let me just say that I love the show so far, and I need to express my gratitude to the organizers for bringing this event together. We're so grateful because, us, the organizers, we would be just a small group of dreamers if it wasn't for the doctors, the dietitians, the contributors who have accepted our invitation to be speakers at this event. So we'd like to thank all of you. Thank you to the panel members as well tonight. My sincere apologies to those of you who are watching that we didn't manage to get to all of your questions. The Romanian Society of Lifestyle Medicine is not going to be swallowed up in a black hole at the end of this Congress. We do plan on sticking around, and hopefully if you didn't have your question answered this time, we will manage to get to your question later on. We would also like to invite anybody who would like to become a member of the Romanian Society of Lifestyle Medicine. Once the Congress is over, please get in touch with us. We're going to also start the membership process for people who want to become a part of this growing movement in Romania. Thank you everyone for making time for us, all the panel members, all the audience. I hope you will all have a good afternoon, depending on where you are in the world, or a good night if you're more towards Europe. Thank you very much, everyone. Take care. Good night.
Thank you.
Thank you. Thank you so much. Thank you, Dr. LOOMIS. Thank you, Dr. Rob. Thank you so much, Dr. Dan. And thank you, Dr. DIEHL, for having so much support for me and for us. And not in the end, thank you, Konrád, for this nice organization, for the panel. And I hope the people did got some of the answer they were having from you. Thank you so much for making this possible for us. Thank you. Bye-bye. Looking forward to invite you here in Romania next year in the in-person event.
Yeah, I also appreciate so much. We've done lifestyle medicine in the clinical setting, but now this is the next level to bring the science in, and appreciate very much doctors for being with us.